Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. So I'm going to talk to you guys today about something called MOSH Syndrome. And in my opinion, MOSH Syndrome, or at least components of MOSH Syndrome, are probably the leading single cause for the low testosterone epidemic that we're seeing in the Western world, and especially in the United States. So MOSH syndrome is Morbid Obesity Secondary Hypogonadism. And in my opinion, again, this is just my conjecture, when we combine this condition with endocrine disrupting compound exposure, which is everywhere and all of us are victim of it, when you combine those two factors, I think it accounts for the vast majority of men who are currently suffering from low testosterone. Just as an aside, what I always recommend to you guys is if you are diagnosed with hypogonadism or suboptimal testosterone, that you ask your doctor why they think that your testosterone is low, because there are many different reasons why your testosterone may be low, and some of those may actually be serious, even potentially life-threatening. It's not very common, but it's something that I think is important to have a proper evaluation of by your doctor. Don't just walk in there with a lab slip with a number on it that shows a low testosterone level, talk about your symptoms, and leave with a testosterone prescription. You have to make sure that you don't have something else potentially more serious. So I just want to make sure that I state that as many times as I can, because I've seen that happen. So broadly, testosterone deficiency hypogonadism is classified into primary hypogonadism and secondary hypogonadism. And I know there's also functional, but I want to just stick to those two because I think it's the most simplistic way to look at this. Primary hypogonadism, this is a problem with the testicle itself. It's usually something structural, anatomical. It can be after trauma. It can be after infection. It can be something like a varicocele, which can be surgically repaired and sometimes restore testosterone production. So it's something intrinsic with the testicle. The hypothalamic pituitary axis is functioning normally. It's just that the end organ is not doing its part. So most men don't have an issue there. Although, as we're going to talk about, MOSH is interesting because it is classified as secondary hypogonadism, meaning not involving the testicle, but involving the hypothalamic pituitary axis. But there actually is an indirect effect directly on the testicle itself. So in some ways, it's a bit of both. So as you can imagine, the root cause of MOSH is obesity, okay? And we have got no shortage of that in this country. So here's a map here showing obesity by state, and there's a lot of red states in here. Okay, this has changed color over the years, and this is somewhat dated. This is from 2017, but 2017 data showed at least 42.4% of Americans were classified as being obese. 12 states had 35% of their population was obese or super obese. So those 12 states, you guys ready? Alabama, Arkansas, Indiana, Kansas, Kentucky, Louisiana, Michigan, Mississippi, Oklahoma, South Carolina, Tennessee, and West Virginia. Good job, guys. Doing awesome. So I'm kind of surprised Texas wasn't on there. I saw some big bodies when I was doing my training down in Texas. But this is a major issue, right? Major issue when your state, if you have over a third of the population is obese, there's that's going to be a problem. That's going to be a problem. So let's talk about some of the definitions. Unfortunately, we're stuck with BMI, body mass index, as the main way that we categorize obesity in almost all of the research studies out there. It is it's used heavily, but it really is it's not an accurate. Well, I shouldn't say that. It is accurate. It's not optimal, because I would argue that there are a lot of people who are suffering from excess body fat that may not meet the weight standards to be classified as obese. Okay, so This is the classification that they currently use. So there's obesity, severe obesity, morbid obesity. So obesity, if you have a BMI is greater than 30, okay, severe obesity greater than 35, morbid obesity greater than 40, and you can see it there, super obesity greater than 50, and then super obesity, BMI greater than 60. So it kind of gets ridiculous, at that level. But the problem with this approach, again, is there's a lot of skinny fat people, for lack of a better term, out there who carry excess amounts of body fat, who are suffering from lipotoxicity, who are suffering from all sorts of health conditions related to excess body fat. They just don't weigh enough to be classified as obese if you use BMI. On the flip side, you have muscular athletes who have BMIs of 30 or above, including myself, who have very low body fat or relatively low body fat percentage and don't have any of the obesity related comorbidities. So, for the general population, it's fine, but using the BMI as your standard is going to miss. It's going to miss a large number of people that they just don't weigh enough to be classified as obese, but their body fat percentages are far from being optimal. So I like the Obesity Medicine Association's definition, and various bariatric surgery organizations also use body fat percentage as a way of classifying obesity, and this is far superior. It just gives you a lot more information. For me, it's a lot easier to work with this than it is with BMI. So what does the Obesity Medicine Association say? So for men, obesity is greater than or equal to 25% body fat. 25%, okay? It's a lot of you out there, 25% or higher. Okay, average adult male, it's about 27%. The average male is obese in this country. And this is a chart here that demonstrates this. Again, this is a few years old, but you can see, they break it down by male and female. Obviously, we'll focus on the male, but at every age group, they're above 20% here. Even teenagers, these days are above 20%, and then you can see. God, the 8 to 11-year-olds, I mean, you're looking at 27, 28%, and you get a little bit of dip in the teen years, but then it goes right back up, as you get older. So this is not good. And obviously for women, it just goes up and up and up, except at the very end of life, you see a little bit of a dip here. And that's because all of these really obese women have all died. It's not that you suddenly lose weight at the end here. It's just that a lot of these women have died. Okay. So, the problem when everybody around you, when you look around and the average is 27, 28% as a man, you might be tempted to kind of look at yourself and be like, hey man, I'm not doing so bad here. Compared to Bob over there in marketing, like I'm looking pretty good, right? And you go into your doctor's office at a body fat percentage of 27%, and that it's unlikely that your doctor is going to be like, hey buddy, you probably got a few pounds to lose. Maybe you could consider doing that, and we can get you off these blood pressure, cholesterol medicines, because that's we're now trained to look at that as normal, but that is not normal. This is a really useful group of photos here from the first one here is from ripbody.com. So it's 6 guys with, just to give you a visual, who have about 25 to 29% body fat. So these men are obese by the Obesity Medicine Association definition. So I don't think anybody would look at these guys, at least today in the medical world, and say, ooh, yeah, man, you're obese. But take a look at these men are obese. These guys are carrying way more body fat than they need to. And they are certainly, as I'm going to show you here in some of these studies, they're certainly carrying enough body fat to negatively impact their health. This is another one just to kind of put body fat into perspective visually, from builtlean.com. So it shows, in the upper left corner here, this is also not healthy, by the way, 3 to 4% body fat, which this is what a high level competitive bodybuilder achieves, right before they get on stage. Super unhealthy. These guys all feel terrible. This is not sustainable. And then, but I want you to make a mental note of this 6 to 7% guy and this 10 to 12% guy, because the next series of photos I'm going to show you are somewhat relevant. But as you go up in body fat percentage, it's not until guys it's been my observation, it's not until guys hit this like 30, 35, and maybe 40% range that they're kind of like, ooh, yeah, maybe I should do something about this. But this is way down the road, for them. And certainly these are the kind of body types. These men almost universally have suboptimal testosterone. I've said this many times. Again, what is normal now is not normal for the human race for 99.9% of our history. Depending on which group of anthropologists you talk to, modern humans have been around for 150,000 years. I'm talking about modern humans, not like archaic, Homo sapiens, but modern human beings, at least 100,000. I know they keep pushing that number back, but this is what normal is for the human race. Okay, so we have this first picture here is a European guy that joined one of the indigenous tribes. I believe it was in New Guinea. So look at these two guys. The native guy, I mean, these are old photos from the early 1900s. Look at that, full on like 8-pack on both of these guys. They're jacked, they're ripped, got big round deltoids there. There's no SARMs, there's no lifting weights. There's a very healthy diet and a very vigorous lifestyle in a difficult climate. All right. And this picture, this is what healthy aging should look like. This is a group of Aboriginal elders. This is also taken in the early 1900s. And, these guys, especially the middle guy and the guy on the right, visible abs on these guys. And these guys were elders. I don't know how old, they probably didn't know how old they were, but they're probably in their maybe late 60s, I'm going to guess. Lean, muscular, fit. These guys could probably run circles around most modern men, even at this age. But again, going back to the body fat pictures, somewhere these guys are probably all of these guys probably like single digit body fat percentages. I'd be shocked if they were above like 10 to 12% body fat. And then this is normal. This is what men should look like. This is what men have looked like for the last 100,000 years. Okay, just the way it is. Okay, so this is a really good paper here. Optimal cutoffs of percentage body fat for predicting obesity-related cardiovascular disease risk factors in Korean adults. So big study done in Korea. This is American Journal of Clinical Nutrition, 2011. And, for a long time I was wondering, okay, well, what is the optimal body fat percentage for health? And there's not very many papers on that can give us good guidance on this, but this one I thought was interesting. They looked at 41,000 Korean men. They also looked at women too, and they looked at the relationship between body fat percentage and cardiovascular risk factors. So they looked at hyperlipidemia, hypertension, and type 2 diabetes. And this is the graph. Okay, super interesting. So they got a group of men. And here we are. This is the men with less than 10% body fat. They just lumped all of those together. And then they went up in increments of like 5%. So the next group was 10 to 15% body fat, 15 to 20, et cetera, et cetera. So look at the prevalence of these cardiac risk factors. It just goes up. From 10% up, it just goes up and up and up. So at every body fat percentage above 10%, there's an increased prevalence of hypertension, diabetes, and dyslipidemia. And for every percentage point or group of 5 percentage points that you go above 10, you're even more likely to have more than one of these, potentially up to 3 of them all at once. So at least in this study, you want to have 10% body fat or less, because as you get fatter, your risk for these cardiovascular cardiovascular risk factors, the prevalence of these cardiac risk factors just goes up. It's a controversial area because there's some studies that came out in the International Journal of Obesity that looked at this, and they were wondering, okay, well, where does, all-cause mortality, where is that the lowest when it comes to body fat percentage in a Western population? So this article here, Body Fat and Risk of All-Cause Mortality, a Systemic Review and Dose-Response Meta-Analysis of Prospective Cohort Studies. So a lot of studies, 35 prospective cohort studies with close to 1 million participants. And this is the graph. So what's interesting about this is that they found, so the lowest body fat percentage here, which they started at 10, and as you got fatter, this is all-cause mortality, so dying from any reason, started to go down. And then it hit the nadir, the lowest point here at somewhere around 25% body fat. And then as you got more body fat, obviously your all-cause mortality started to go up. If you look at this, you'd be like, well, shit, I just need to be 25% body fat, and that's going to put me at my lowest, my lowest risk for all-cause mortality. But that's not really true here, because we're looking at an adult Western population, and this is general. There's a lot of elderly people in the study. Many of them are over the age of 60. So in the modern world, having really ultra low body fat percentage, being down around this 10% group, most of the time that's not. So they didn't go and sample NFL cornerbacks and wide receivers in this study. These are just average people out, living their lives. So the average person that has these very low body fat percentages in the Western world, I would argue, is likely suffering from some form of chronic disease, or they're chronically malnourished. So I see it all the time with like emphysema, COPD patients, these frail, like super cachectic, like skeletal, especially like little old ladies, but men too. They're called pink puffers as opposed to the blue bloaters. So those of you guys who take care of COPD patients are familiar with those terms. These are people that have cancer, cachexia, so they're wasting away. They're elderly people that live alone and are nutritionally compromised. So yeah, today in the modern world, many of the people that have very low body fat percentages are not the healthiest. And so it makes sense in this study that you put a little meat on their bones, and then their mortality risk goes down. But that doesn't mean that being 25% body fat is optimal for you. Okay, so there's a little bit of a sampling bias here that you just need to be aware of. I still wonder about this, but it seems to me that probably the optimal body fat percentage overall that's also sustainable is it's somewhere between, I want my guys somewhere between 10 and 15%. That seems to be optimal. We do have pretty good data from from natural bodybuilders that when you start getting down into single digit body fat percentages, your testosterone levels start to drop. You start having other endocrine issues as well potentially. So there is such a thing as being too lean, unless that's just your genetics. But yeah, somewhere between 10 and 15% is probably optimal, and that's what I think most people should shoot for. Okay, let's talk about MOSH a little bit. So the information I'm going to give you guys and some of the diagrams that are to follow come from these two papers. So the first one, this is from the journal Nutrients. It was 2017, I believe. 2018. It's called MOSH Syndrome, Male Obesity Secondary Hypogonadism, Clinical Assessment and Possible Therapeutic Approaches. This is a paper this is where I actually first learned about this term when I first read this paper shortly after it came out. And then this is another one here that's also really good. It's from the journal Obesity. It's 2018. Male Obesity-Related Secondary Hypogonadism, Pathophys, Clinical Implications and Management. Okay, two really good papers if you want to get into the weeds on MOSH. That's what it is. So this is kind of a bird's eye view here of the hypothalamic pituitary axis and in a normal person, and then what it looks like in somebody who has MOSH. So we'll start down here in the bottom left corner here, normal adipose tissue. So somebody who's lean, fit, muscular, your adipose tissue, it secretes an adipokine called leptin, which is quite beneficial for a number of reasons. So fat tissue is an endocrine organ. I don't know if a lot of people don't know that. A lot of physicians don't know that. It secretes like well over 100 different substances. most of which in excess are harmful, but there's a few that are actually beneficial, and leptin is one of them. So leptin actually stimulates kisspeptin. So kisspeptin is at the very top of the hypothalamic pituitary axis. These kisspeptin secreting neurons, they secrete kisspeptin. Kisspeptin stimulates these GnRH neurons. They secrete GnRH. GnRH goes down to the anterior pituitary. The anterior pituitary gland secretes LH and FSH, and lo and behold, you end up making testosterone and sperm at the testicle. Okay, I think most of you guys are aware of this axis. You may not know about the kisspeptin, but kisspeptin's up at the very, very top. And again, in normal circumstances, leptin does its thing, and you have a nice functioning axis here. Everything is good. Okay, over on the right, in this MOSH individual, now things are not good. So now it says here, hypertrophic adipose tissue. That's putting it nicely. So you're morbidly obese. You have huge amounts of not just subcutaneous fat, but visceral body fat, which is particularly pro-inflammatory. So it releases all of these, evil humors, for lack of a better term. Estrogen, it goes through the roof. Well, maybe not through the roof, but you do have increased aromatase activity. And, a lot of guys are aware of the role that, or they understand intuitively that, when you become obese, you aromatize testosterone to estradiol to a greater degree, and that is true. And that does play a role in the negative feedback. But the role of leptin, I don't think most people know about leptin, and leptin is a major player in this. So the amount of leptin in your system is directly related to the amount of body fat you have. So, leptin's a good thing, right? Well, when you have these high leptin levels, you develop leptin resistance. You no longer respond to leptin. And so that signal to the kisspeptin neurons now is not as strong as it was before, because it just can't respond to leptin anymore. So now you have less kisspeptin. Less kisspeptin means less GnRH. Less GnRH means less LH and FSH. Less LH and FSH means less testosterone and less sperm. Okay, this is a much busier slide. Here showing some of the same details, but a little bit more. We'll start here with the fat cells, and we'll just run through this quickly. And the purpose of showing you this is just to show how this is like a vicious cycle. Okay, so again, we have all of this dysfunctional, pro-inflammatory, visceral and subcutaneous body fat. It causes all sorts of issues with hypothalamic inflammation. It causes insulin resistance. And so we come up over here, and then so now we have leptin resistance, we have insulin resistance. I mentioned the pro-inflammatory cytokines. We have like TNF alpha goes through the roof, interleukin 1, interleukin 6. All of these have a down regulatory effect on the kisspeptin neurons. It just shuts them down. And we know less kisspeptin, the end product, LH and FSH from the pituitary, also goes way down. Okay. Now we also have high circulating estradiol from aromatase activity, which shuts things down just in and of itself. So now you have this massive inhibitory signal going to the kisspeptin neurons that just are shutting down testosterone production. These high leptin levels, or I should say, it's actually the leptin resistance. It directly inhibits steroid production in the testicle itself. So it actually causes the Leydig cells to shut down steroidogenesis and not produce testosterone. So not only are you shutting down the hypothalamus, but the testicle itself is being shut down by leptin resistance. And again, a lot of guys don't know that. They just kind of focus on the estrogen part of the obesity equation, but really it's estrogen, it's inflammation, and it's leptin resistance. So major problem. What are we going to do about this? Well, you got to lose weight. Right? Easier said than done. Okay. But really, weight loss does work. Losing weight will improve men's testosterone. I don't just mean losing weight. I mean specifically losing visceral body fat, because that's the root cause of all this trouble, right, with your testosterone levels. So this is just a very simple graph here, a bunch of different patients. This is collated from a number of different studies. They just looked at total testosterone, and then they got a baseline, and then after just 10% weight loss. Okay, I mean, in almost all of these, you get a nice little bump in your testosterone, and 10% is not that much. These guys were still pretty obese even after 10% weight loss, but just 10% made a big difference, right? So really, you got to get the weight off. You need to have a comprehensive approach to this, and you need to work with your doctor, work with a trainer, work with a coach, to address the obesity, because that really is the problem. Now, the question of whether you're going to go on testosterone replacement is a personal decision. Obviously, many men who are suffering from this condition are so tired and so fatigued that they can't find the drive and the motivation or the energy to just get off the couch to do the work, to do the exercise. So, yeah, I mean, in most cases, it's obviously perfectly appropriate to treat those men. I would argue too, though, that especially this is a big problem it's getting to be a big problem in younger and younger men. So I would say that in certain populations like them, or in men that maybe don't want to commit to long-term or lifelong, testosterone therapy, maybe they don't like the idea of shutting down their own axis, that using enclomiphene for a specific period of time in order to raise their testosterone levels, hopefully get them feeling better, and then allow them the drive, motivation, and energy to implement the lifestyle changes to help them lose weight. And then maybe if they lose enough, they could potentially come off of it. If it doesn't work, obviously, then they can go on, routine, testosterone replacement therapy. But, the testosterone obviously should be addressed. In my opinion, it's going to make all of this easier. Specifically, what I mean by that is the weight loss part of it. But just taking testosterone, guys, is not going to be enough. I see it all the time here on the forums. I've seen it in patients. These guys come in, they're morbidly obese, they got classic MOSH syndrome. You put them on testosterone, and yeah, a lot of them do feel better. But they don't lift a finger. All right, they still eat like crap. They still make every excuse in the book not to get to the gym and not to exercise. And 6 months to a year into testosterone therapy, they've either lost no weight, or some of them have actually gained weight. Which is it's such a terrible missed opportunity and such a waste of a golden, like a second chance when guys do that. It drives me absolutely crazy when I see it. So, the treatment for this is not to fix the testosterone per se. That is one part of this. You need to get on. And if you need help, you need to reach out. As men, we're not so good at asking for help when we need it, especially from professionals. But you need to get help, with your diet. If you need help, especially out of the gate with weight loss medications, the GLP-1 agonists are an option for a lot of these guys. Bariatric surgery is an option. I'm not a big proponent of that initially, but I mean, the data is very clear. It does work. Okay. Most of you guys have no idea how to work out, and that's a fact. Okay. So get with a trainer, get with a coach, go with somebody who can teach you how to lift weights, teach you how to properly do cardio, do so in a manner that's not going to get you injured. Okay. It's not something that men are born knowing how to do, okay? You need to learn how to exercise properly. And, this is maybe for another talk, but a comprehensive program to minimize your exposure to endocrine disrupting compounds is critically important. These comes from plastics and cooking with Teflon and fast food and, processed food in general. So, you can read about that. The Endocrine Society has some literature on it. There's a lot of other good sources that you can see out there online. But avoiding endocrine disrupting compounds is super important, not just for you, but for your kids. I worry about this condition with kids, for not to go off on a side here, but right now, and at least in the preceding generation, men are developing MOSH after they've, in adulthood. So they've already gone through puberty. So at least they had a relatively normal puberty with a normal testosterone level, which allowed them to develop a normal male masculine brain. Well, now, again, with these like 200-pound 8-year-olds that I see in the emergency department, those kids, they're going to go through puberty with a stunted testosterone and blunted testosterone level, not to mention the rest of their endocrine issues, their insulin resistance, their prediabetes, their fatty liver, etc. And I wonder what that's going to do to their brain development, in their teens and early 20s. Because remember, your brain doesn't fully develop, especially the frontal lobe, it's not until your mid 20s. And a big part of that in a man is having a healthy, robust testosterone level. Well, if your 14 and 15-year-old never gets above 300 or 350 for a total testosterone, which I've seen many times because they're obese and they've been exposed to endocrine disrupting compounds, what kind of man is going to come out on the other end of that? I don't know, but probably not an optimal one. Let's put it that way. When you start implementing this stuff at home, make sure you bring the rest of the family along for the ride in terms of these healthy behaviors. And then the other thing, that I really want to touch on, and again, it can be an uncomfortable subject for a lot of men. You have to address what are the underlying reasons. How did you get to 350 pounds? Okay. That didn't happen overnight. So, how did you develop this unhealthy relationship with food? Do you have trauma that you need to talk about? You have to kind of own that you have an eating disorder. You don't get to 350 pounds without disordered eating, in my opinion. Again, I'm not a psychiatrist. I'm not a mental health provider, but that seems like a reasonable statement. So, you need to peel that onion a little bit, and, doing so under the guidance of somebody who's a professional is probably in your best interest, right? Because you don't want to do all this stuff and then just gain it all back again. You want to address the underlying issues that cause you to overeat in the first place. And, I see it all the time with bariatric surgery patients. I have personal friends that have eaten right through their gastric bypasses because, and not only regained all the weight, but then they ended up fatter than they were before their gastric bypass, which I didn't even think was possible, but it is. The surgeons, are more than happy to do the surgery for you, but, a lot of times they leave these patients hanging and they don't get them into therapy and they don't get them the psychological help so that they don't go back to their old eating habits. All of us have habits that we're not proud of, and getting some help to look at that is super, super important. So anyway, I don't want to go too far down the road on that, but you got to look yourself in the mirror. It's part of being a man is being brutally honest with yourself and say, hey, listen, how did I get here? And if you don't know how you got there and you don't know how to get out, is part of being a man is asking for help. Okay. And that's a big part of what I do in this practice. I don't give you psychotherapy, but we're certainly going to talk about your eating. We're going to talk about your medical issues too. So anyway, that's all I have for you guys today. I wanted to make you aware of this condition in case you ever hear about it. It's called MOSH, MOSH. And again, it is in my opinion, this is probably the leading cause of at least secondary hypogonadism in the Western world. The take-home message, if you're 25% body fat, you are obese. If a quarter of your body mass is fat, it's too much. You need to get that body fat percentage down. You need to start building lean muscle tissue, and the optimal is probably 10 to 15%. Please let me know what you think in the comments, and I will catch you guys next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.